First of all, I would like to thank Department of Pediatrics and Professor Shali Avasthi and all the faculty members for giving me an opportunity to talk on this occasion to my Almamentarium colleagues and also the seniors and the juniors. So this is a very great opportunity, and I am privileged and honored to be a part of alumni. And so I just am going to share my screen. Is it visible?
Yes.
Yes, sir, it's visible.
It's visible.
So I have chosen this topic because this is what I am having a specialization and also a deep interest at AIIMS Jodhpur. So this is one of the important things which, as a pediatrician, also we come across daily. And I would say that the pediatricians are the most important component of the medical genetics. And since the pediatricians have a good clinical acumen, and they also have the acuity of diagnosing and dealing with the patients, and they are also family members. So they are in a very good position to counsel these patients. And also there are challenges which are there, which are produced because of the genetic conditions. And sometimes we require some skill and some collaboration so that we can help these patients who are having this problem, which cause a lot of burden on the society. So we know that many of the conditions in the pediatrics have a genetic basis. And most of the common among them are the polygenic disorders, which include the asthma, psychiatric problems, dysmorphology, also include the birth defects, congenital anomalies, metabolic disorders, which can occur intrauterine or can be identified prenatally or after birth also. And they are all important causes of morbidity, disability and death. Singularly, they are very rare, but collectively they produce a heavy burden on the society and the healthcare. So I will be discussing about the overview of what we already know about the genetics as a pediatrician. Then what are the common challenges in the diagnosis and management? And then what are the possible solutions and the approaches which are now being explored by the scientists globally and our experience at AIIMS Jodhpur. So we know that we classify the genetic disorders under the 4 heads: chromosomal disorders, which includes the numerical as well as the structural abnormalities, single gene defects, which can be of 4 types. Then the multifactorial disorders, which are now assuming to be more important, and with the biotechnology as advancement and the NGS technology, more of these disorders.
If you could be a little louder, please, or maybe speak into the mic. Voice is not very clear.
Okay. So I will just try to speak a little louder. So, is it clear now?
हाँ बोलिए तो पता चलेगा.
Just 1 minute.
Hala, it may be some local issue because यहाँ पे तो बहुत clear सुनाई दे रहा है in my office.
अच्छा ठीक है फिर.
Others also can say, is Dr. Kuldeep audible? You can write in the chat. He's audible, na? Yeah. तो शुरू करिए डॉक्टर साहब.
Okay. So another group of disorder which are following the inheritance from the mother is a this Mendelian disorder which do not follow the Mendel's law. Apart from that, there are some epigenetic phenomena which may change the behavior of the gene and may not exactly fit into the single gene defect or even follow the multifactorial disorders. So medical genetics as such is a science of human biological variations as it relates to the health and disease, while the clinical genetics is that part of the medical genetics which is concerned with the health of the individual humans and their families. So it has a more implications for the in the public and the community as well as the general practice. Clinical genetics can also be defined as a science and practice of diagnosis, prevention and management of the genetic disorders. As we know that the medical genetics has come a long way since 1865 when the Gregor Mendel's experimented on the pea plants. Then the first very most important landmark or the milestones was the correct chromosome number identification in 1956. Then in 1959 they were able to microscopically visible chromosomes can be demonstrated in Down syndrome. since then, there's a lot of changes have occurred, and now we have the Human Genome Project, which completed in 2003, and recently we have also completed the gapless genome in March 2022. So Human Genome Project is one of the most important achievement of the mankind, which shows the collaboration. It is a project because of international collaborative research, and it deciphered the human genome in 3 major ways. It determined the sequence of all the bases in the human, made the maps that show the location of the genes on the chromosomes, and also produced the linkages maps. So the disease or the association of the disease can be linked to the maps on these chromosomes. And the first draft of the human genome was published in Nature in 2001, and finally it was declared in 2004. And recently in 2022, they have even sequenced the whole of the 8% of the unexplored genome as well. Now, anything which is left is that individual country-wise or ethnicity-wise, there is a need for exploration. So medical genetics has a lot of roles in various disorders, including our common pediatric practice. For example, there are some of the common conditions which are related to the eye, to the blood, to the cancers, to the hormone deficiencies and disorders, to the storage disorder, which are now coming up very fast. And the special interest is given to the storage disorders because they can be managed sometime by the BMT and also by the enzyme replacement therapy. Dysmorphic disorders are also very coming up, and they needs a lot of clinical judgment and acumen. Dysgenesis of the organs of various parts in the body, tall and short stature, variations in the BMI, cardiovascular disorders and neurological disorders. They are some of the common where the role of the genetics is very far-reaching. It cannot be done by a single person. There is a need for a team. So the team consists of a physicians or a pediatricians or obstetrician and the genetic counselors with the clinical diagnostics facility, laboratory diagnostics facility, radiological support with the ancillary services like nutritionist and the rehabilitation services. And also when the team is working, then also we need a research team which can help in the collaboration and finding out the infrastructure for research into these areas. So what armamentarium we have at present? So one of the best known to everybody is the chromosomes, which is like deciphered in the form of karyotype. So it can diagnose disorders which leads to the numerical abnormality or structural abnormalities, including the deletions and duplications. The advancement of the karyotype over the fish has led to finding out the deletions or duplication in a shortest period of time. But sometimes very finer defects or very small abnormalities can be missed because they are subjected to the subjective variations. The second, which is of a larger area, is the chromosomal microarray. It is able to detect the clinically significant microdeletions or duplication with a high sensitivity for even the submicroscopic aberrations. And it has a power to detect as small as 5 to 10 kilobyte in size and a resolution up to 1000 times of the conventional karyotype. So nowadays the karyotype is now becoming less popular except for certain conditions, and chromosomal microarray is available for wide array of conditions. And because it detects the copy number variation and it is thought to play in the role in the pathogenesis of various disorders, including the neurodevelopmental and congenital anomalies, so its use has now been increased. The simple steps is that the patient's DNA and the control DNA are hybridized on a microchip, and they are then analyzed with the help of a software which give rise whether there is what is the comparative difference between the patients and the control DNA, and it can help in the microdeletions and the duplications. So chromosomal microarray can detect the copy number changes simultaneously at multiple loci. So that means it is equivalent to the concurrent fish over thousands of loci. And the target array CGHS, also known as microarray, is used to evaluate the specific segment of a specific chromosome, a chromosomal part of the chromosomal segment, or a specific DNA dosage abnormalities, or even the rearrangement in the chromosomes. So usually it is helpful for the diagnosis, counseling and reproductive planning, and also guiding the prognosis for the patient with certain conditions, including the hematological malignancies and other cancers. It yields in the children with the MR with or without dysmorphism is as high as 10%. But it is not always useful. It has some limitation because it cannot detect the point mutations. Sometimes the dying duplications cannot be detected. Balanced chromosomal rearrangement also cannot be detected. And most of the CMA cannot detect mosaicism if it is below 20 to 25%. So CMA ultimately leads to a diagnosis of around 10 to 15% of all the genetic abnormalities, which is significantly better than a 3% yield of a chromosomal analysis. So here is a case. This baby M presented with the feature of motor delay, clinodactyly of the second and the fifth toe, and the facial dysmorphism in the form of low set ears, macrognathia, triangular faces, relative microcephaly, prominent forehead, and feeding difficulty. She also had the postnatal growth failure. So when the chromosomal microarray was performed, it indicated the loss of the chromosomes of 3.6 MB of chromosome 4 with a cytoregion which is designated at 4p16.3, indicating the monosomy of this region. So this is a prenatal anomaly. There is an overlapping syndrome of a similar conditions. And there are 44 OMIM genes are involved in this. And one of the commonest known syndrome is Wolff-Hirschhorn syndrome. It is a congenital malformation syndrome characterized by the pre- and postnatal growth deficiencies, developmental disabilities, and some craniofacial abnormalities. So this is a chromosomal microarray can help if there is a unknown cause or suspected genetic disorder with dysmorphism. Next, we can go for a single gene sequencing, which is possible through the help of Sanger sequencer. Now, the Sanger sequencer is available with the multiple 4 capillaries, 8 capillary, or 12 capillary, and they are very important in determining the unique and specific disorder of the DNA basis. And also, it compares the patient sequence with the reference sequence. So, single nucleotide change, even such as the base substitution or a small insertion or deletion, can also be detected with the help of Sanger sequencing. When one gene is significantly more likely than the other genes, then that have been associated with the same conditions, it is more likely to detect with the help of Sanger sequences. It also provides the comprehensive coverage within a single gene. And also it is used for confirming the diagnosis even with the next generation sequencing. If there is a sequence abnormality, we have to confirm with the help of Sanger sequencing whether there is a mutation or not. But the limitation is that it can detect only 500 to 800 base pair mutations or abnormalities mutations. So another technique is MLPA, that is MLPA is used for fluorescent tags probes are used for multiple ligations and amplifications. And the DNA of the patient is compared in sequence. So the presence of the extra probes indicates the duplication, while the absence of the probe indicates a deletion. So mostly it helps in detection of the dystrophin gene, which is harboring large deletions and duplications. So this is the MLPA, in which there is hybridization is carried out after denaturation and ligation with another, with the methylated and the unmethylated target, and then it is compared with the help of software. Next armamentarium we have is the multi-gene panels, and among this, the most of the time we are using nowadays is the NGS, next generation sequencing, that is also known as expanded panel testing, massively parallel sequencing, or high throughput sequencing. It is the combination of the NGS methods or the array platform together works and allow many genes to be sequenced simultaneously. So the microarray can give a picture that okay, there is some problem in that region, and with the help of NGS we can narrow down that region and analyze it with the help of bioinformatics software. It also determines the unique and specific order of the DNAs which are compared to the reference sequence. Single nucleotide changes such as single base substitution and small deletions or insertion can also be detected with the help of NGS. Another is multi-gene panel. When you have a clinical defined condition that can be achieved with a mutation in a number of genes, this NGS multi-gene panel can help in that. When the person in the family history are suggestive of more than one hereditary syndrome, here also this will helpful. And when there are multiple candidate genes, and also this gene panel of clinical exomes will be helpful. So based on this armamentarium which we have, we can make the diagnosis process in the following way. First of all, it's very important for the pediatricians to know about the clinical characteristic of the patient. So clinical characterization is the most important thing and includes the detailed personality and the family history, review of the current data about any known condition with a similar description. Then the next important step is very important, that is the pre-testing counseling. Now this counseling is another separate subject because there's a lot of issues in the counseling. We stay as a simple process, one activity, but it is not like this. Genetic counseling is a process which continues for a long time, and it takes into account the circumstances in which it is given to the patient and the family. So we have understood the familial circumstances, their psychological makeup and other important information before the testing can be done. So pre-test counseling is very important and takes into account whether they are able to take this psychologically, whether they are fit to take it psychologically, whether they have changed their jobs or they have shifted to some new organization or something new place. Then also it should be better to delay it till they get adjusted to that, unless until it is an emergency condition of the prenatal diagnosis. Next step is ordering the appropriate genetic test. Again, this depends on our experience. If we are experienced to have that thorough knowledge about which test is appropriate for which condition, we can go ahead. After the test report is available, it should be reviewed, and this test report should be carefully examined with the calculator, and also the post-test counseling should be advised to the family, to the patient, to the couple before this is disclosed. So they should be counseled about that the report is available, and this may change the way you are dealing with the pregnancy or your child care or the further management of the child. So that should be taken into account. Then the ultimate step is to manage the condition, and here comes the role of the multidisciplinary approach in the management, and which includes the quality of the care, quality of the life of the child. So this is a Master A. He was a 10-year-old boy who was in case of severe visual impairment. So this was doctor shopping for many years, and he was 10 years old. The diagnosis was not established. The parent approached because the mother was pregnant again. So this was a reason for approaching us, that the mother was pregnant and she was having a period of gestation of 10 weeks. So clinically, characterization of this child shows that he was a terminally. There was no history of an ICU stay. But within the first month of the life, the parent realized that the child was not fixing and focusing the eyes, and they visited multiple hospitals over a course of next 2 years, and they were performed of the poor visual prognosis center. Then CT scan was done, which was suggestive of the persistent hyperplastic primary vitreous, PHPV. And this is a pedigree. And when we went into the detail of this pedigree, then we found out that on the mother's side, there was many male members having a similar presentation. We reviewed the literature, and multiple genes were involved in the normal retinal development. They are known as NDP genes. So NDP gene is a X-linked recessive condition that can cause the PHPV. So we decided to go ahead with the retinal degeneration panel for Master A, and this is a report which was available. So it was a context region which was corresponding to exons 2 and 3 of the NDP gene, and it was likely to be deletion of the region in that region of the gene. It was homozygous deletion. The fetal testing also says that there was a heterogeneous deletion of the exon 2 and 3 of the NDP, which was same as that in the index patient. So the need to counseling decide about their family whether they want to continue with the pregnancy or not. So due precautions were taken about disclosure of the sex of the child, and they were apprised about this information. Another case was Mr. B, who said that you are deaf and they were found to be suffering from bilateral sensory hearing loss. This is a pedigree which shows that multiple members of the family are affected. And then we went for the NGS, and this found the pathogenic variant, which is homozygous, and that was responsible, but the inheritance was recessive in character, but it was pathogenic and may cause this problems in the child. But again, here the important step is that the counseling should be very non-directive nature, because now we know that most of these conditions can be managed post-birth, postnatally, with the help of cochlear implant. So a cochlear implant should also be considered with the family, and the decision should be left to the family whether they should go for the child or not. So this is another child who is a 13-year-old male who presented with a history of multiple pigmented lesion on the face. There was no significant past history, including the parental history, and there was some suggestion of intellectual disability in the mother. We examined, and we find there was web neck, coarse faces, short stature, and multiple grouped follicular papule over the eyebrows. With the help of dermatology department, we narrow it down to Alma genes. This is a condition which is characteristic with the rasopathies, and along with this differential diagnosis for cardiofaciocutaneous syndrome or Noonan syndrome. So we ordered for the clinical exome test, which came out to be pathogenic with a autosomal dominant pattern of this in the chromosome exon location, and exon 13 was affected in this family, in this child. So this proved that the child was having a Noonan syndrome. So next step is that we go for the whole exome sequencing. Now, whole exome sequencing is a little tedious job to perform, because it requires a lot of each individual database can range from 30 GB to 100 GB, and analyzing this genome required a lot of expertise in the bioinformatics, because it sequences the whole of the entire coding region genome, and it is helpful in condition in which there is a difficulty in diagnosing with the above test, and or if the patient or the family is having multiple illness in the same patient. So some of the common challenges we come across while we are dealing with these tests and the patients with these conditions is most of the time, sometimes the parents come when the index patient may not be available at that time. They just give a history that somebody in the family is having this problem, and then we call them, or sometimes the patient has expired, that child has expired. So in that case, it is very difficult. This is a common challenge we face in our genetic counseling clinic. Second is that antenatal case comes, and at a later stage, at around 18 to 19 weeks, when present that there is an abnormality in the fetus. Here comes the role, that is how we have to counsel them. And now when we go about the cost of these tests, it ranges from karyotyping may detect some of the chromosomal abnormality alone, and the cost can be up to 5,000. It takes a long time, up to 2 to 4 weeks. Chromosomal microarray can range from 10,000 to 20,000. Sanger sequences may range from 3,000 to 5,000, but it is not available in centers, but some of the places it is available in the institute itself. Targeted panel sequencing can take up to 20,000. Whole exome sequencing can go up to 24 to 35,000. And in some of the skeletal dysplasia, it can go up to 1 lakh or even more than that, because a lot of things are required in the sequencing, and sometimes we have to take the help of some other laboratories around the world. Counseling in the genetic disorder is also very difficult, because first of all, they have a genetic disorder, then they go for the anger, then they also fail to understand the implication of the test. And they are just happy that okay, the test has been done, but they don't understand the real implication of the test. Also, it causes a lot of issues in the family, in the extended family also. So it leads to a lot of challenges when we are dealing with these patients in the genetic counseling or genetic clinic. Sometimes there is a identification of the variants of unknown significance. This creates a lot of psychological stress in the family, and also the pediatrician also and the clinician also, they are not able to say confirmatively whether it is true or not. So it has been found that because the diagnosis of a genetic disorder depend on the gene discovery, the whole exome sequencing can only detect up to 25 to 30%. That means that 70 to 75% are still left without a diagnosis. And among these, 5 to 7% of these patients may have more than one disorder. Again, they create a problem in the counseling. It has been found that despite the popularization of the whole exome sequencing and laboratories throughout the country and the world, they are doing WS, but there is a now plateauing of the WS-based rare diagnosis gene discovery. And the reason is, and of the one challenge, that is, this means that the critical documentation of the pathogenic variations in the same gene in at least 2 unrelated individuals with the same rare disease that is required to confirm a novel disease is there. So that's why there is a plateauing in the extent of diagnosing with the help of WEs. Second is there are sometimes complex genetic mechanisms like structural variations, tissue-specific mutations, somatic mosaicism, splicing and regulatory mutations, gene imprinting, oligogenic and digenic inheritance, and gene-environment interactions, which are also known as epigenetic phenomena. They all influence the clinical phenotype of the patient, and we fail to understand why the genetic variation is not producing the clinical picture. Another challenge for the rare disease is that there are around 6,000 to 8,000 rare disease is an estimate, and it is clear that there is a far from one-to-one association with the disease and the genes, with more than 30% of the disease genes causing more than one rare disease because of the pleiotropy and because of the other factors. There is a lack of understanding of the clinical heterogeneity, variable expressivity, penetrance, and epistatic interactions, which also modify and produce challenges in the rare disease and the genetic conditions. Many well-recognized genetic conditions may have a wider spectrum than the previously we have thought of. So when the report is available, we go and look back the child again, and we found some more conditions and more problem with the child which are not described in the literature. So again, this also has to be taken into account. And the patient with the genetic condition which are identified by a genomic test like NGS may not conform to the pattern we expect based on the experience of the patient with the same condition identified by a single gene testing. So it can be very difficult to be sure whether this reflects an incorrect diagnosis or a representation of the wider spectrum of the disorder than the previously recognized disorder. So all these complexities are now leading the pediatrician to think in depth about all these conditions, and we have to think about larger picture, broader picture, rather than just restricting ourselves to the genetic testing. So when all these reports are available, it makes the genetic counseling more complex and challenging. And especially it becomes more challenging when the patient is coming for a prenatal testing. Here, the whole of the family is disturbed. They are confused whether to continue with the pregnancy or to abort. They bank on the advice of the geneticist or a pediatrician or a obstetrician at what they will do if they are in the similar situation. So they try to emotionally blackmail the clinician also in that situation, and becomes very challenging. So we have to understand that we have to think about something which we can give a accurate description in the form in a manner in which they can comprehend, they can understand and take a decision along with the discussion with the family members to go about or to abort or to terminate the pregnancy or to continue with the pregnancy. Again, we may explain that, okay, this is a pleiotropy effect may manifest later in the life also, and we cannot say with 100% certainty that this will cause a certain disorder. Another challenge with the genetic disorders are that there is a lot of problem with the drug. Drug therapy is often not available, and sometimes the pediatricians think or the clinicians think that there is no role of the geneticist or no role of the genetics to provide the information to the family, because there is no cure for the condition. But they don't understand that there is still life of the child or life of the person is involved, and there are options which are available. The same situation happened in the West, when they recognized that there are more than 70% disorders for which there is no cure. In that situation, they went for empowering the families to take the collective effort to maintain the child, develop some innovations so that can improve the quality of the life of the patient till the child is or the person is alive. So in the drug development, another issue is the regulatory approval. As we know, in the clinical trial, there are a lot of issues are involved. Unless they are emergency like COVID, the drug DCGI approval for these therapies are not so forthcoming. And sometimes the regulatory approval may take as long as 5 to 7 years. Now, the special type of trials may be ordered, they may be permitted, but again, considering the current annual rate of 35 new approvals, which is more than the double in the last 10 years, still it is not sufficient. Because if we are thinking about the 500, 600 predicted new treatment over the next decade, based on our further incremental increase in the orphan drug approval, still there is a 90% of the rare disease will be left without any treatment. So even if there is a 500, 600 new treatments which are there over 10 years, there is still chances. So that's why there is a need for looking into depth in the research in this area for the clinical trials. Now, another issue is the challenges of the efficiency. That means the data in silos, they are built around a single or a small group of rare disease. So once the family comes, we just concentrate and we also glamorize the thing in the media around the single case. And this limits our understanding of the connections across the rare disease. One rare disease may be connected with the other rare disease and may have a similar type of presentation or similar type of treatment options. So this working in the silos, which lead to identify more efficient, lead to development of the more efficient strategies to advance the rare disease diagnostic. We have to think about the therapeutic agents which can be used for this disease, outcome measurements. That is, what is the outcome of these patients with the different interventions. Then the epidemiological research, public health, and the health services research, which is also very important. And so all these, when we think about a single gene defect or a single rare condition, all these are affected because their efficiencies are decreased. Similarly, the health technology assessment, which is the measure of the economic evaluation and the burden to the society, is difficult to apply when we think about a one disease or a group of disease only. Other challenges are the social inequity, mostly because it is a family-centered, so there is a tendency of the family doctor or a pediatrician to target those who garner more attention. So because in Rajasthan it happens that one of the family with the Gaucher disease conditions, they move the court and they garner the attention of the media, and they want the therapy to give to their child. So this is against those with the greatest need, and sometimes these are not picked up. The children with the sickle cell disease, thalassemia, may require more attention because they can be treated, but they receive less attention with the media. And also that's why there is a need for empowering the family with the disorders having the minority affection, like sickle cell disease. So in the US also, in the Europe also, there are challenges with the minority. So when the cystic fibrosis versus sickle cell disease was compared, there was more interest for the gene therapy and intervention development for the cystic fibrosis because this was affecting the European or the American populations, whereas sickle cell disease which was affecting the African population, was neglected. Similarly, there is a lack of research infrastructure for epidemiological studies. We still do not know, not only India but globally, what is the exact range of these disorders in the society. And also there is a deficient translational research where the research information can be applied for the public health. There is also challenges in the sustainability because rare disease diagnosis outpace the management of the services and the skill available for treating these disorders. So with the NGS now we are diagnosing more condition, but still our target is on the diagnosis alone. We never target or think about what is the life of that individual after the diagnosis. How much care we can provide to the family or the society. So I think these are the challenges which need to be addressed, and this is a forum and the platform by which I would like to address the pediatrician of KGMU to think about all these things. So there are solutions also. When we talk about the challenges, there are solutions, and there are several research and policy generation initiatives which can be taken. That is, we have to think about the clinical trial design for the small population. We have to identify the models of the real world evidence, and also we have to redefine the clinical endpoints at which we have to engage with the family and the patients. And also there is a need for regulatory interaction which are based on the health technology assessment. There is also need for a development of the new standardized framework integrating all these elements. And there is a pressure and movement towards such new practices with the ongoing decision on the financial sensitivity for the rare therapies will always be helpful. So one of the approach is deep phenotyping. This is where the pediatricians stands out because they are in a best position to precisely and comprehensively analyze the observable traits that are consequences or the outcomes of the genetic or epigenetic phenomena. Another approach is algorithmic approach, that we have to target, that we have to go first of all the microarray if it is possible, then we have to go for the sequencing or the NGS. And once the diagnosis is made, we should not stop. We should extend the family screening. And also there is a need for collaboration. Not duplicating the things. Suppose if the one institute has NGS, there should be little effort on the duplication. We can use this with the help of now the paper-based testing. We can transport the samples anywhere in the country or the world. And we have to develop the network. And there is a now more requirement of the integrated approach with the geneticists, pediatricians. And what is that when we talk about the deep phenotyping, it progress from the clinical picture to the molecular and laboratory. And from the macro level, from the clinician's point of view, and micro level, from the transcriptomics, proteomics, biological pathways, and metabolomics. Now, another area which is new development is a matchmaker exchange platform, MME. Now, this use of this database or the exchange program has indicated that such approaches are useful and they facilitate discovery and also management of these disorders. This platform was launched in 2013 and it integrates with the software programs to provide the information to the caregiver and also the families. So these are the whole of the this matchmaker platform, which is now having a lot of interaction and collaboration with most of the other database as well as the clinical associations. Like there is a Decipher. Decipher is one of the unique system working in the UK, along with the collaboration with throughout the world. From the India also there are many collaborators which are a part of that Decipher. Similarly, there are undiagnosed disease network. They are also working in that area. So now, with the help of digital healthcare technology, now there's AI is one of the most important bridging gap between the technologists and the pediatricians or the clinicians. We have to make use of this. For this, we required a history of the data, omics data generation, multiple data with the integration with the open data, and then this decision-making software is used for providing the decision to the clinicians. Another area is reverse phenotyping. Now, one project has been launched in India from GBT, from Hyderabad. And what they are doing is that any patient suspected to have a clinical phenotype of having a suspected genetic disorder, they may be offered a first NGS. And then the sequencing is confirmed with the help of sequencer. And then the further phenotype characterization is done for that patient based on the genotype. So this is known as reverse phenotype, also known as genotype and phenotyping. This is one of the example where they have used for the nephrotic syndrome children, and they have reached to further phenotyping of this condition as 6 having Alport syndrome, 3 had Dent disease, and 3 other monogenic disease. So this is most useful for clinical decision making using the reverse phenotyping. So this involves geneticist, clinical expert, and lab expert. Clinical cases of the patient undergoing whole exome sequencing can be again discussed through this platform. Now we have an array of database which are available publicly. That is the Human Phenotype Ontology, Phenotypes, Phenomizer, Omin, PACE2Gene, and POSUM. So these all can be used for diagnosing of this patient and narrowing our diagnosis. So medical genetics is relevant in all the specialty, especially in the pediatrics. And at AIIMS Jodhpur, we started a medical genetic clinic in OPD in 2013. In 2019, as a piloting project, DBT initiated under Umid initiative, established a Nidan Kendra at AIIMS Jodhpur. In 2020, we joined hand with the Genome India. And 2021, we start our own DM medical genetics program. So this is a Nidan Kendra in which there is a genetic clinic and laboratories. And the aim of this Nidan Kendra is to provide the counseling, prenatal testing, and diagnosis and management of the common disorders. And sometimes we have to take the help of the other people in the network. So clinical genetic clinic at AIIMS Jodhpur runs from Monday to Friday. And till now, the confirmed 963 patients in last 3 years have been identified, and they include the patient with various conditions, including the dysmorphic syndromes, metabolic disorders, skeletal dysplasia. We have a registry of around 82 Down syndrome patients, 142 muscular dystrophy, Duchenne muscular dystrophy, Turner syndrome with 10, and spinal muscular atrophy around 40 patients, and they have been confirmed with the in-house digital droplet PCR. So prenatal testing is also available at AIIMS Jodhpur. We have carried out this 286 procedure, and we have identified almost all type of disorder with the help of different technology which are available at our hand. Laboratory services are in the form of Nidan Kendra having the manpower, and we have the facility for DNA extraction. Digital droplet PCR has been restricted, and this can provide the SMA screening for at as low as 500 rupees. Thalassemia also is standardized procedure available. We are working with the cytogenetics and biochemical department for providing the ancillary services to these patients. Role of collaborations cannot be undermined. We have a Center for DNA Diagnostics at Hyderabad, IGIB at New Delhi, AIIMS Delhi, SGPGI, University of Exeter from UK. Then we have International Skeletal Dysplasia Registry, One Health Consortium, which takes into account the environment, human, and the genotype, and they are also working in that area with the biotechnology. And Genome India Consortium with 25 centers throughout the country, they are working on this project. So research also, we are doing a lot of research in different area. And Genome India is one of the important project which is the main initiative by the DBT. Apart from that, we are doing the clinical research in the form of effectiveness of the genetic counseling, caregiver burden for the prenatal disease and disorders, genetic education, and sickle cell in the tribal population of Sirui with the help of Ministry of Tribal Affairs and the NHM. So future development which need to be done is standardization of the procedures, expansion of the diagnostic services for the further clinical karyotyping, including the innovations, and starting of the genetic counseling, collaboration with IIT Jodhpur with AI, and also one of the important international collaboration which has been matured at AIIMS Jodhpur is the India-Sweden collaboration, where one of the area is precision medicine. And the precision medicine, the most important component is the clinical precision and the deep phenotyping. So these are some of the areas, and I think I will stop at this juncture and take questions about the genetic challenges and how we can help the patient with these disorders.
Thank
Thank you so much, sir, for such an excellent and lucid talk. And I would say it was a very interesting approach to the common genetic conditions that we pediatricians encounter in our day-to-day practice. I would like the audience to ask any questions.
I think it was a very interesting presentation called Dr. Kuldeep, very informative. And this year we have also got a Nidan Kendra like you had it since 2013.
Yes, ma'am. That is very congratulations, ma'am. That is
Yeah.
We are establishing around 32 Nidan Kendra for the country. I think this genetics is going to progress further.
Yes. So my simple questions were to you, like, how would you know? A lot of mutation studies are coming up, many PhDs, many MD theses are coming up. So how would you know that this mutation, this polymorphism which they are doing, that is it of clinical significance? Because it can be just like that random. So in simple words,
yes, that is very important, ma'am. Actually, this is a very important concept from our. Yes. So, ma'am, actually, the people in the clinical departments and the laboratory people, they were working differently, and they have a different approach, different attitude and aptitude. While the laboratory people, they are more concerned with the laboratory part only, and they are concerned with detecting a mutations or something abnormality. The clinicians, on the other hand, they are more concerned with the patient management, safety of the test, and their reliability of the test. So now with the COVID time, there's a lot of handshaking has occurred between the laboratory people and the clinician. And there's now translational research are going on different fields. AIIMS has also initiated that dual degree MD-PhD program to bring these laboratory part and the clinical part together so that it can be translated into the. So when we suspect a clinical conditions based on the clinical conditions, or just randomly sometimes when we are not able to identify the condition infectious or autoimmune, we order for a test. Sometimes we order for a panel, and then we get the report, okay, there is some variation, and then we have to go to the literature whether this variation has been reported in the ClinVar or any other database, and whether the features are fitting with our case or not. Sometimes we have to go depth on that, and we have to ask the information about the NGS panel or this point mutations from the company or the laboratory, so that we can find out some other regions which can be there which can explain this condition. So this process of approaching in this way, when we identify the mutation first and go in a reverse direction, that is a reverse phenotyping. And nowadays, this is a technique which will increase the number of cases with a known or even unknown variations. And this will increase the complexity of the pediatricians to provide the services. Because whether this variation is of significance, whether it is going to hamper the life, in what way it will affect the patient's life or any drug or any other disease in the future, that remains unanswered. And that's why there is a now role for integrative medicine. That is integrating all these specialty into one, and we have to work in a collaboration. Then we can justify that whatever mutation we have and really explain the situation or not.
Thank you very much. It's a very complex and very nice reply, and we are trying to understand this, because many times we do case control studies, we find such and such is associated, and then we try to see what is its translational value. And I guess we need to do a lot of collaboration with people like you who are hardcore genetics and pediatricians to inform us. Over to
your research area will be very useful, because epidemiological studies are everywhere in the world. Epidemiological studies about these are very limited, and sometimes as a pediatrician we just report a case, but from the public health point of view, and from the if we want to go for the research infrastructure for these conditions, there is a different approach is required.
I would like the audience, if they have any other questions, sir would be happy to take it.
Good afternoon, sir. Sir, I'm Dr. Shani.
Dr. Shani, yeah.
If you remember me, we are the part
Yeah, sure. Prenatal rubella syndrome.
Such a nice lecture. Sir, actually, I just want to ask that many times because of the multiple presentation which is not fitting into one, and we are just all the tests, and then if the patient, which is very rarely is affordable in our situation because patients are really poor, so we are able to do the WAS or clinical exome. So then 2-3 genes they come up, and then there's some gene is pathogenic, some they write unlikely, some are like uncertain significance, and then उसमें से जो clinically हमें लग रहा है sometimes they label it non-pathogenic और clinical picture में कुछ और fit हो रहा होता है, mismatch हो जाए, तो फिर how to make a decision from my point of view, because the gene which is they are saying in the report and there is a mismatch, although whenever we send these samples we take care to communicate well with them because they should be important to gel and to communicate the history of the patient. But then, if for example, in one patient suddenly Zellweger syndrome came out, and we were not suspecting that out. It was just a case of encephalopathy. So, when the patient expired, we communicated report to the parents, but it was difficult to understand the significance of that report.
Yeah, Dr. Shalini, this is a very important dilemma, and which every pediatrician face when they come across a rare condition. And this is but natural. But again, it can happen both ways. They identify some mutation which may not be contributing to the phenotype, and sometimes we detect the phenotype which is not conforming to the genotype. So here again, sometimes we have to target both. That is, we have to think about the child as a whole, whether our concentration should be more on the management, providing the quality of life and other options which are available for management, whether surgical or medical. We should explore that also. In the meantime, we can explore this whole of the NGS panel data with some other like we can compare with some other test also. So there are some facilities available. As I said, that there is a panels of experts throughout the world. They are working on some of the rare condition. So they are known as undiagnosed condition. So there is a undiagnosedinternational.org, and you can also register and you can share your data. This data which is available for Genome or any other NGS panel, and that you can say that this is a clinical phenotype, and I would like to know whether there is any other condition which can be suggestive of this syndrome or a condition of encephalopathy. In that way, they will come out with an answer. Even in our center at Jodhpur, Dr. Varuna Vyas, she is very active in exploring all these database. She used a computerized algorithm also. She feeds this data on some of the software, and they find out, okay, there is some other condition which is there, and then she reconfirm from the this biotechnologist whether it is confirming to that or not. So I think both way collaboration is required, and we have to sometimes go for the reverse phenotyping, find out whether this mutation may be really a part of the Zellweger syndrome or not.
Yes, sir. Thank you so much.
Thank you, sir. Are there any more questions from the audience? So I would now request Dr. Siddharth Kumar to propose the vote of thanks.
Thank you, Dr. Arpita, and thank you, Dr. Kuldeep. We have had initial association, and then you grew out, and we are still here. We knew that the challenges in diagnosing and managing genetic conditions were there, and we just expected to know the possible solutions and approaches. But now we know that there are more and more challenges when we could understand. So, and the journey you took us through, starting from the fish, then karyotyping, then CMA, then single gene sequencing, and PA, and then now presently the polygenic and gapless genome. So journey was really encouraging to read more. What I can say, we just can level ourselves as a lay pediatricians at this time, like laymen in other things, and we are the lay pediatricians or lay physicians But this bird eye view is really encouraging to read more. And as you said, this is the solution lies in associations as well as integration. So we will try to integrate, we will try to associate with you and others. And in case, because we all have problems in my area in pediatric intensive care, we do have inborn errors of metabolism where we cut this thing. So what I can thank you not enough is that the interest has regrown, because we just thought this is not our matter, but I think we have to endeavor. And as you said, the deep phenotyping is we can definitely contribute with the deep phenotype. So thank you so much. And we will expect more and more lectures and association in this field, because you are a master of the game.
Yes, definitely we'll be ready. AIIMS Jodhpur will always be ready with the KGMU to collaborate.
And I really thank our HOD and Dr. Arpita for continuing such a good lecture series, and it's really enlightens us regularly.
And my video has started working suddenly.
Yes.
I kept logging on and logging off. It's working. So I can see, and Kuldeep can really see me. I paid attention to entire lecture. Thank you so much. Any other questions from anyone? Otherwise,
Thank you so much, ma'am. Ma'am, we've prepared the e-certificate if you would like to.
Sure. Please. We would like to award an e-certificate to Dr. Kuldeep from our KGMU.
I hope it's visible.
Not at least not visible to me.
Okay, ma'am.
Not now. Previously it was visible.
It may take some time.
Ma'am, I'll try once more.
कोई बात नहीं, उसको एक बार ट्राई कर लो.
Yes.
Give our regards to Sanjeev Mishra, Kuldeep.
Okay, ma'am. Sure, ma'am. Thank you very much.
Thank you so much, Dr. Kuldeep.
Thanks a lot.
And when you come to Lucknow, do visit us.
Surely, ma'am. Surely.
Because your home is still here, na? In Lucknow.
Yes. वहीं पे है, same place.
यहीं पे parents.
Yeah.
Definitely, I'll come.
Yes, please. Okay, thank you.
Okay, thank you, ma'am.
Thank you so much.
So nice. Thank you so much.
Thank you.
Thank you, sir. Thank you very much.
Thanks all. Thanks everyone.
Thank you so much, audience, for the patient hearing. Thank you.